Usually when we talk about a medical diagnosis, there's this expectation of like total precision.
Right. It's binary. Like, it's either broken or not broken.
Exactly. It's like
Oh.
engineering. You break your arm, the x-ray shows that jagged white line,
Hmm.
and the doctor just points and says, well, there it is.
It's clean, it's visible, and frankly, it's comforting. We really like our problems to be neatly categorized and just easy to point at.
But then you step into the world of hypertension, high blood pressure, and suddenly that x-ray machine is completely useless. You just can't see the problem.
No, you can't. It is the absolute definition of pharmacological muddy waters.
Right, because instead of a clear x-ray, you're standing in your kitchen, staring at a pharmacy bag just full of orange pill bottles. You've got ACE inhibitors, ARBs, calcium channel blockers, diuretics.
And you're just wondering, what are all these actually doing inside my body? Because you can't feel the pressure in your arteries.
No.
And you definitely can't feel the enzymes shifting in your liver.
Yeah, but those little pills you swallow with your morning coffee, I mean, they're performing incredibly complex, highly targeted chemical interventions every single day.
They really are. It's fascinating.
So today on the Deep Dive, we are going to translate those chemical interventions into a practical, memorable, and honestly fascinating guide for you.
We have some incredibly dense source material today. We're looking at textbook excerpts on the pathophysiology of hypertension, lifestyle interventions, and a really detailed breakdown of all the major drug classes.
Yeah, we're breaking down the mechanics, the severe warnings, the bizarre side effects, and the everyday clinical realities of how these blood pressure medications actually work. So, okay, let's unpack this.
Let's do it.
Because before we can talk about how the drugs fix the problem, we really need to understand what the problem actually is. So mechanically speaking, what is blood pressure?
Well, if we connect this to the bigger picture, it is essentially fluid dynamics. It's a plumbing system.
Okay, I love a good plumbing analogy.
Right. So the foundational equation in cardiology is that blood pressure equals cardiac output multiplied by peripheral vascular resistance.
Wait, okay, let's break that down. Cardiac output, that's the pump, right?
Exactly. It's how hard and how fast your heart is pushing the fluid, the blood through the entire system.
So if you break cardiac output down further, it's just your heart rate multiplied by your stroke volume.
Right. And stroke volume is the literal amount of blood ejected with each individual heartbeat.
Which is usually what, around 60 to 90 milliliters?
Yeah, right around there.
Yeah.
Imagine a small shot glass of blood just being forcefully squeezed out every second.
Okay, so that's the pump. And then the other half of the equation is peripheral vascular resistance. So those are the pipes.
Precisely. It's determined by the degree of constriction or dilation in your arteries and arterioles. We call it vascular tone.
So if the pipes are wide and relaxed, the resistance is low.
Yes, the fluid flows easily.
But if they're clamped down tight, the resistance is really high.
Right, so if the pump is working overtime or the pipes are too narrow, the pressure inside the system just skyrockets.
Okay, but here's where it gets really interesting to me. The tissues in your body actually control their own local blood flow.
Yes, they do. It's a concept called autoregulation, and it's a critical survival mechanism.
How does that work?
Well, your major organs like the heart, the brain, the kidneys, they are incredibly demanding. They constantly need to preserve their oxygenation.
Right, they can't just wait around for the central nervous system to figure it out.
Exactly. So local tissues act like little independent contractors. They actually produce their own vasodilating and vasoconstricting substances.
Oh, wow. So if a tissue lacks oxygen, or if, say, carbon dioxide or lactic acid is building up from exercise.
It releases chemical mediators to literally widen the pipes right there locally.
Okay, so things like histamine, serotonin, prostaglandins, and a very important one called bradykinin.
Yes, bradykinin.
We're going to talk a lot about bradykinin later, so definitely put a pin in that one. But basically, the tissues are constantly shouting at the blood vessels, hey, send more blood. Or, we're good, clamp it down.
That's a perfect way to describe it. Now, when this entire system, the pump, the pipes, the chemical messengers is working in perfect harmony, you have normal blood pressure.
And normal, according to the modern guidelines, the American College of Cardiology and the American Heart Association, normal is a systolic pressure, the top number, right?
Right, when the heart is actively squeezing.
Less than 120. And a diastolic pressure, the bottom number, when the heart is resting and filling of less than 80.
Under 120 over 80. Got it.
And the modern thresholds just kind of step up from there, right?
They do. Elevated is 120 to 129 over less than 80. Stage 1 hypertension is 130 to 139 over 80 to 89.
And stage 2 is anything greater than a 140 over 90. But then there's the really terrifying one, the hypertensive emergency.
Yeah, hypertensive emergency or crisis. That's a systolic pressure of 180 or more, and or a diastolic pressure of 120 or more.
180 over 120. That's incredibly high.
At this level, the physical force of the blood is so violent that it significantly increases the risk of acute target organ damage.
Like, the pipes can literally burst, leading to a stroke.
Exactly. The clinical goal in the ER is to lower that blood pressure safely within 24 hours.
Because if you don't control high blood pressure,
Yeah.
I mean, even if it's not a full-blown crisis, you run into what the sources call hypertensive-mediated organ damage, HMOD.
Right. It's the silent killer aspect of this whole disease.
Because you might feel totally fine for years, right?
Yeah.
Maybe you have a vague headache or some fatigue.
Yeah, but inside, the sheer mechanical pressure is micro-tearing the delicate pipes in your kidneys.
Yeah.
It's blinding the vessels in your eyes.
And forcing your heart muscle to grow really thick and stiff just from overwork.
Exactly. And we really have to ask why the body just lets this happen. Why doesn't it just fix itself?
Right. If it's so smart with autoregulation, why does it let the pressure stay so high?
Well, the reality is that the body's compensatory mechanisms are actually quite flawed because they evolved for a completely different environment.
Oh, interesting. How so?
Let's look at how the body responds to hypotension, low blood pressure. In human history, low blood pressure usually meant you were bleeding out or severely dehydrated.
So it was an immediate death sentence.
Right. So the body hits the panic button to save your life.
Ah, okay. So when pressure drops, the sympathetic nervous system, the fight or flight response, is stimulated.
Yes. Epinephrine and norepinephrine just flood the system. And at the exact same time, the kidneys trigger something called the renin-angiotensin-aldosterone system, the RAAS.
The RAAS, okay. And what does that do?
It makes the kidneys retain fluid, it constricts the blood vessels to raise resistance, and it hoards water to increase the overall blood volume.
Because more fluid and tighter pipes equals higher pressure.
Exactly. It keeps you alive long enough to heal from the trauma.
But when arterial pressure is chronically elevated, which is what modern hypertension is, the body's response is incredibly inadequate, isn't it?
It is. It just doesn't know what to do with chronically high pressure. The kidneys try to excrete a little more fluid to reduce the blood volume.
And the vascular endothelium tries to produce vasodilating substances, like nitric oxide, to relax the vessels.
Right. But eventually, in hypertension, these regulatory mechanisms just break down. The panic button basically gets stuck in the on position.
Wow. Which leads us to the difference between primary and secondary hypertension. Because the sources are very clear on this distinction.
Yes, secondary hypertension makes up about maybe 5 to 10% of cases, and it has a specific identifiable cause.
Like a tumor on your adrenal gland just pumping out adrenaline, or severe kidney disease.
Right, and if a surgeon removes the tumor, boom, the secondary hypertension is cured.
But primary or essential hypertension,
Right.
that makes up 90 to 95% of all known cases.
Exactly. Historically, medicine called the cause unknown, but that's really a misnomer today.
Right, we know it's a massive tangled web of genetic variations, behavioral choices, and environmental factors. It's multifactorial.
Absolutely. A body mass index higher than 30, high alcohol intake, insulin resistance, a sedentary lifestyle, high stress.
And high salt intake, right? At least in salt-sensitive people. And these factors just stack on top of each other.
They do, which brings us to the baseline defense. Because before a prescriber reaches for that orange pill bottle, we have to look at how your body responds to behavioral changes.
Right. The leading clinical guidelines, like JNC-8, they emphasize lifestyle modifications as the absolute first non-negotiable step.
And the data shows it works beautifully. Take the DASH dietary approaches to stop hypertension.
Okay, yeah, that's a diet abundant in fresh fruits, vegetables, and low-fat dairy.
And what's amazing is that the blood pressure lowering outcomes of the DASH diet actually parallel the exact degree of benefit you'd get from taking a single pharmaceutical blood pressure medication.
Just from changing your food. That's incredible.
It really is. And we absolutely have to talk about sodium here because the cellular mechanics of sodium are central to this entire disease.
Okay, let's get into it. Severe salt restrictions aren't usually realistic for most people, right?
No, usually not. But moderate restrictions aiming for maybe 4 to 6 grams of salt a day are highly beneficial.
And here's why it matters on a pharmacological level, based on our sources. Sodium restriction actually potentiates, meaning it boosts and synergizes with the antihypertensive actions of diuretics and other drugs.
Yes, let's unpack that because it's a huge light bulb moment for a lot of people. Excessive sodium intake actively decreases the actions of all antihypertensive drugs.
Wait, all of them? Why?
Because water follows salt. It's a basic rule of physiology. If you take a pill to widen your blood vessels, but then you eat a massive salty meal.
Your blood becomes thick with sodium.
Right. So your body hoards water to dilute that salt. Suddenly, your blood volume expands massively.
Oh. So you've completely overwhelmed the medication. The salt actively fights the drugs.
It's a localized tug of war, and the salt usually wins.
Wow. Okay. Now, if we connect this to physical activity, aerobic exercise, we're talking 40 minutes per session, 3 to 4 times a week for at least 12 weeks. The sources say that can decrease systolic blood pressure by 5 to 8 millimeters of mercury.
It can. And achieving a weight loss goal of just 10 pounds if you are overweight takes a massive load off the pump.
So every single lifestyle change, diet, exercise, weight loss, limiting alcohol, stopping smoking, each one knocks another 4 to 5 points off your systolic pressure.
Exactly. You can essentially build your own medication out of habits.
I love that. Build your own medication. But this raises an important point about treatment goals, because the target isn't universally 120 over 80 for everyone, is it? Demographics matter.
They matter immensely. Based on the 2018 clinical guidelines, if you are a healthy adult 60 years or older, the treatment goal is actually a blood pressure of less than 150 over 90.
Wait, really? Why let it run that much higher in an older adult? Doesn't that risk organ damage?
It's a delicate balance of risks. You see, as we age, our blood vessels naturally lose their elasticity. They stiffen up.
Okay, so think of them turning from flexible rubber hoses into rigid PVC pipes.
That's a great analogy. Now, if you aggressively push an 80-year-old's blood pressure down to 110,
There simply isn't enough pressure to force the blood up against gravity through those stiff pipes into the brain.
exactly, you risk severe dizziness, orthostatic hypotension, dangerous falls, and cognitive impairment just from a lack of brain perfusion.
Oh, wow. So you actually need a slightly higher pressure just to keep the system flowing properly.
You do. However, if that patient over 60 has diabetes or chronic kidney disease, the vessels in those organs are already so compromised that the goal tightens back down to less than 140 over 90 to protect them.
That makes perfect sense. Protect the fragile filters. But here's where it gets really interesting to me. I want to push back on the lifestyle and diet thing for a second.
Okay.
The clinical data from our sources shows that nearly 70% of the familial considerations related to blood pressure are attributed to shared genes rather than a shared environment or eating the same salty foods. So do different ethnicities actually metabolize these drugs differently? Because if so, that fundamentally changes how we prescribe them.
It is a massive deal, and the pharmacological evidence absolutely supports this. Management strategies must account for race in drug selection because the underlying pathophysiology can differ.
For example, individuals of African American descent often have lower circulating renin levels and a much higher incidence of salt sensitivity.
Right, so the RAAS system, the renin-panic button in the kidneys, isn't the primary driver for their high blood pressure. It's more about fluid volume and salt retention.
Ah, okay. So because of this physiological difference, ACE inhibitors and ARBs, which specifically target the renin system, are often far less effective as a solo therapy in African Americans.
Precisely. The guidelines highly recommend starting with a calcium channel blocker or a thiazide-type diuretic, which targets the fluid volume and vessel walls directly.
Okay, and what about other populations? Because the data highlights a fascinating specific detail. People of Asian descent often need much smaller doses of beta blockers because they metabolize and excrete them incredibly slowly.
Yes, the drug just builds up in their system, and the exact same slowed metabolism goes for Arab Americans, Egyptian Americans, and possibly German Americans.
It just highlights how personalized medicine is becoming completely non-negotiable.
Okay.
You cannot just throw the same pill at every single person and expect the exact same pharmacokinetic result.
You really can't. The liver enzymes and genetic blueprints are totally different.
Which is the perfect transition into our first class of heavy hitters. Because when the DASH diet and the treadmill aren't enough, we bring in the A-team part 1, the ACE inhibitors, the enzyme blockers.
Yes, ACE stands for angiotensin-converting enzyme. The prototype drug in this class, the one all the others are compared to, is captopril.
Okay, so if you're holding a pill bottle, the cheat code here is looking at the suffix. Almost all ACE inhibitors end in allopril. Captopril, lisinopril, enalapril, benazapil.
If it ends in pril, it's an ACE inhibitor.
So, mechanically speaking, what exactly is this drug inhibiting? Let's break down the action.
Okay, let's trace that panic button system we mentioned earlier, the renin-angiotensin-aldosterone system.
Yeah.
When your kidneys feel like blood pressure is too low, or if they're just malfunctioning,
They secrete a substance called renin into the blood.
right, renin travels around and eventually leads to the creation of a protein called angiotensin the first.
Hmm.
Now, angiotensin the first is basically harmless. It's inert.
It's just floating around minding its own business.
Exactly. But then, as that blood flows through the tiny capillaries of the lungs and the blood vessels, it meets the angiotensin-converting enzyme, the ACE.
Okay.
This enzyme grabs that harmless angiotensin the first and rapidly converts it into angiotensin the second.
And angiotensin the second is an absolute menace, right?
Uh-huh.
It is one of the most potent, powerful blood vessel constrictors in the human body.
It violently clamps the pipes down tight, immediately spiking the pressure.
Not only that, angiotensin the second acts as a messenger to the adrenal glands, which sit right on top of the kidneys.
Right. It triggers them to release a hormone called aldosterone.
And aldosterone's entire job is to tell the kidneys to aggressively hoard sodium and water and to kick out potassium.
So now you have constricted pipes and a massive influx of fluid being pumped through them.
A perfect recipe for devastating high blood pressure. So our central drug, captopril, steps in and blocks that angiotensin-converting enzyme. It intercepts the process.
Yes. The harmless angiotensin I never gets converted. The menace, angiotensin the second, is never created.
Because there's no angiotensin the second, the pipes relax and widen. And because there's no aldosterone, the body stops hoarding salt and water, and the blood volume drops.
The mechanism is really elegant. Pharmacokinetically, captopril is well absorbed orally, though food significantly reduces its absorption.
Oh, so the clinical teaching is strict there. You must take it on an empty stomach 1 hour before or 2 hours after meals.
Right. It acts quickly, peaking within 1 to 1.5 hours, and it's mostly excreted unchanged in the urine.
And these drugs are therapeutic superstars. I mean, they aren't just for hypertension. They are foundational for heart failure.
Absolutely. By lowering the pressure, they decrease the workload on the heart. And they actually prevent or even reverse the physical remodeling and thickening of heart muscle and blood vessel walls.
So if you have a heart attack, being put on an ACE inhibitor significantly improves your chances of long-term survival.
It does, and what's truly fascinating is their protective effect on diabetes. ACE inhibitors are highly recommended for adults with hypertension who also have diabetes and early kidney damage.
Because they actively slow the progression of albuminuria, right?
Yeah.
Which is the spilling of vital proteins into the urine.
Yes, they reduce the pressure specifically inside the delicate filtration glomeruli of the kidneys, preserving renal function for years.
Okay, so they sound like miracle drugs. But let's talk about the adverse effects, because there is one that is absolutely infamous. The ACE cough.
Oh, yes, the ACE cough.
Why does taking a blood pressure pill make you hack up a lung?
Well, this goes back to bradykinin, that tissue messenger you penned earlier.
Right. The local tissue shouting at the pipes to open up.
Exactly. Bradykinin is a substance your body naturally produces that has strong vasodilating properties. It relaxes blood vessels, which is great for lowering pressure.
Okay.
Now, the angiotensin-converting enzyme, the exact enzyme we are intentionally blocking with the drug,
Yeah.
it also happens to be the enzyme responsible for breaking down and clearing out old bradykinin.
Ah. So if we block the enzyme to stop angiotensin the second, we are simultaneously, accidentally, stopping the garbage disposal for bradykinin.
Precisely. Bradykinin builds up in the body, and while it helps lower the blood pressure, it also accumulates heavily in the respiratory tract.
Which irritates the airways, causing a persistent, dry, non-productive, extremely annoying, tickly cough.
It happens in a significant percentage of patients, particularly females. And what's frustrating is that it can take 1 to 4 weeks, and sometimes up to 3 months, to fully go away after you stop taking the drug.
That sounds incredibly disruptive. But there's a much more dangerous, life-threatening side effect related to that exact same bradykinin buildup, isn't there? Angioedema.
Yes. Angioedema is a sudden, severe hypersensitivity reaction. Because bradykinin makes blood vessels leaky, massive amounts of fluid can suddenly shift into the tissues.
Oh, wow.
This causes deep swelling or welts under the skin, particularly around the eyes, the lips, and the tongue.
Crucially, it can swell the throat and completely close off the airway.
Exactly. If a patient ever experiences angioedema on an ACE inhibitor, it is an absolute lifelong contraindication. They can never, ever take an ACE inhibitor again.
Another thing to watch out for is first-dose hypotension, especially in patients who are severely dehydrated or already on water pills.
Right. The pipes relax so quickly on that very first tight pill that their blood pressure completely bottoms out. They stand up and immediately faint.
So the clinical workaround is usually taking that first dose while lying in bed at night so you sleep through the extreme drop.
Yeah, that's standard practice. And we must thoroughly discuss hyperkalemia. Dangerously high potassium levels in the blood.
Let's trace that. Remember the cascade.
Yeah.
ACE inhibitors block the creation of aldosterone.
Right, and aldosterone usually tells the kidneys to keep sodium and excrete potassium into the urine.
So if we block aldosterone, the kidneys do the exact opposite. We lose the sodium, but we aggressively hoard potassium.
Which leads to a crucial piece of patient teaching. A lot of people diagnosed with high blood pressure immediately try to get healthy by using salt substitutes on their food instead of real sodium chloride.
But what is actually in those salt substitutes? Potassium chloride.
Exactly.
So if you are taking an ACE inhibitor, your body is already hoarding potassium. If you then sprinkle a salt substitute all over your dinner, you are dumping massive, unchecked amounts of potassium into your blood.
That can literally stop your heart by causing fatal electrical arrhythmias.
That is a critical safety alert that I feel like is often missed. No salt substitutes, and patients need to exercise caution with consuming huge amounts of high potassium foods, like bananas, oranges, or spinach while on these drugs.
Absolutely. Let's touch on the demographics and age warnings for ACE inhibitors because they are stark. For neonates and young infants, they are highly sensitive.
Captopril has been directly associated with nephrotoxicity, severe kidney damage in neonates.
Right. The doses used are microscopic, like 0.03 to 0.15 milligrams per kilogram.
But the most severe warning, a literal FDA box warning. The strictest alert they issue concerns pregnancy.
Yes. ACE inhibitors are highly teratogenic. They directly cross the placenta and affect the developing renin-angiotensin system of a growing fetus.
So if a patient becomes pregnant, these drugs must be stopped immediately at the very first positive pregnancy test, right?
Without a doubt. They cause catastrophic fetal malformation, skull defects, and fetal death, especially during the second and third trimesters.
It's an absolute hard stop, no debate. Okay, let's look at the other pills briefly, because the pharmacology actually varies a bit.
It does. And elapril is interesting because it's a prodrug.
Which means the pill you swallow is actually inactive. Your liver has to metabolize it and break it apart into its active form in alaprilate before it lowers your blood pressure.
Right. And fosinopril is uniquely very slowly absorbed. Lisinopril, which is one of the most prescribed drugs in the world, is unique because it isn't metabolized by the liver at all.
It does its job and is excreted entirely unchanged in the urine.
Exactly. Mosopril has to be taken in a fasting state because food significantly delays its absorption, and drugs like quinapril, ramipril, and trandelapril are all highly effective, long-acting options.
They're often using combination pills with thiazide diuretics, right, to target multiple mechanisms at once.
Yes, that's very common.
So let's set up a scenario. Your doctor puts you on lisinopril. It works beautifully. Your blood pressure is 115/75. Your kidneys are protected.
Sounds perfect.
But you develop that persistent, maddening beginning cough. You can't sleep, you're coughing through meetings at work. Do you just have to live with it to save your heart?
Not at all. That is exactly when we pivot to the 18 part 2, the ARBs, or angiotensin II receptor blockers.
Okay, and the cheat code for this class. They all end in sartan. Losartan, valsartan, candesartan. If it's a tesart, it's an ARB.
The prototype here is losartan.
So how does losartan fix the cough problem while still lowering the pressure?
It's all about precisely where the drug intervenes in the cascade. Losartan doesn't stop the angiotensin-converting enzyme. It doesn't care about the enzyme at all.
So it lets the body go ahead and manufacture all the dangerous angiotensin the second it wants.
It does.
Wait, it lets the body make the ultimate vasoconstrictor. Why would we want that?
Because losartan acts like a massive bouncer at a VIP nightclub.
Okay.
The angiotensin II travels through the bloodstream, acting like a rowdy patron looking for its specific receptors, the AT1 receptors.
Which are the VIP rooms located in the heart, the kidneys, and the smooth muscle of the blood vessels.
Right. The angiotensin II needs to bind to those receptors to cause the pipes to constrict. But losartan is already standing at the door. It physically blocks the receptor.
Oh, so the angiotensin II is locked out. It floats right by, completely powerless.
That is brilliant. It blocks the vasoconstricting and the aldosterone-secreting effects right at the tissue level, rather than stopping the manufacturing process.
And because it completely ignores the ACE enzyme.
It doesn't affect the breakdown of bradykinin. The garbage disposal keeps running.
So bradykinin doesn't build up in the lungs. Therefore, The occurrence of that persistent dry cough is exceedingly rare.
Exactly. So you get all the incredible benefits of an ACE inhibitor protecting the kidneys, helping heart failure, dropping the blood pressure without the hack.
The pharmacokinetics of losartan are wild, too. We really have to talk about liver enzymes here.
Yes, losartan undergoes rapid first-pass metabolism in the liver, specifically by the cytochrome P450 enzymes.
These are the liver's primary chemical processing plants.
Right. When you swallow losartan, these enzymes grab it and process it into an active metabolite that is actually 40 times more potent than the original drug you swallowed.
40 times. That's incredible.
That super potent active metabolite is largely responsible for the drug's long duration of action. Maximal concentrations in the blood hit within 1 to 2 hours.
But patients need to know that the maximal blood pressure lowering effects might take 3 to 6 weeks of daily use to fully manifest, right? You really have to be patient.
It's not an overnight fix.
Are there any adverse effects? Because aside from the wait time, it sounds like a perfect drug.
They are generally very well tolerated, which is why they are so popular. You can see some dizziness, muscle cramps, maybe some heartburn or diarrhea.
And like ACE inhibitors, because they still ultimately block the effects of aldosterone, hyperkalemia, high potassium is still a distinct risk, especially in older patients or those with existing kidney disease.
Right. And while they don't directly cause angioedema by building up bradykinin, clinical data shows there is a slightly increased risk of cross-reactivity for patients who have a history of angioedema from other causes.
Now let's talk about drug interactions, because this highlights a bizarre physiological paradox in the source material. There are herbs and foods that drastically alter losartan's effects.
Yes.
St. John's wort, an over-the-counter herbal supplement people take for mood, actually decreases the effects of losartan.
Yes.
But grapefruit juice, which we usually think of as making drugs stronger, also decreases the effects of losartan. How does that make any sense?
It all comes back to those cytochrome P450 liver enzymes we just mentioned. St. John's wort is an enzyme inducer.
Okay, so it puts the liver into overdrive.
Yes, causing it to chew up and spit out the losartan way too fast before it can really do its job.
And grapefruit juice.
On the other hand, it is an enzyme inhibitor. It blocks the specific CYP enzymes from working.
So if the enzymes are blocked, they can't convert the losartan into that super potent active metabolite that is 40 times stronger.
Right, so the drug's efficacy drops dramatically.
It's so wildly specific. A glass of grapefruit juice at breakfast totally neutralizes your blood pressure medication.
It's a chemistry game. As for patient teaching, unlike captopril, losartan can be taken with or without food.
But it carries the exact same severe FDA box warning as AC inhibitors, right?
Right.
Absolute teratogenic. It must be stopped immediately upon pregnancy or it will cause fetal death.
Yes, same exact warning. Looking at the other sartans in the class, candesartan and irbesartan are noted in the data to be slightly more effective in reducing raw blood pressure numbers than losartan.
And olmesartan has a very strange adverse effect profile. It occasionally causes a sprue-like enteropathy, which is severe chronic diarrhea and weight loss that mimics celiac disease.
Right. And valsartan is uniquely available in a suspension liquid form, which interestingly has a bioavailability about 1.5 times that of the tablet form, requiring careful dose conversions.
Okay, so we've tackled the hormones, we've wrestled the RAAS system to the ground. Now let's look at a class of drugs that takes a completely different approach.
They don't care about the enzymes, they don't care about the receptors.
No, they go straight for the physical muscle of the blood vessels. Let's talk about the C team, the calcium channel blockers.
The muscle relaxers. A very common suffix for this class is gestapine, amlodipine, nifedipine, phenylephrine.
The prototype here is amlodipine. Okay, wait. Muscle contraction, picturing flexing my bicep.
Yeah.
But blood vessels don't have biceps. How exactly does calcium make a hollow tube squeeze shut?
We have to look at how muscle cells work on a microscopic level. For any muscle in your body to contract, whether it's your skeletal bicep, your cardiac heart muscle, or the smooth muscle wrapping around your arteries like tiny rubber bands.
It needs calcium ions.
Yes. During an electrical depolarization, calcium channels in the cell membrane open up and calcium rushes into the cell.
So calcium acts as the spark plug.
Exactly. It binds to proteins inside the cell and physically pulls the muscle fibers together, causing a contraction.
So amlodipine steps in and physically plugs those channels. It inhibits the influx of those calcium ions into the cardiac and smooth muscle cells.
Precisely. If there's no calcium entering the cell, there is no spark plug. The smooth muscle simply cannot contract. It is forced to relax.
The blood vessels dilate, they widen out, the pipes open up, peripheral vascular resistance drops, and the blood pressure falls.
Amlodipine is well absorbed orally, and food doesn't mess with it, but it's kind of a slow burn, right? Peak plasma concentration takes 6 to 12 hours.
Yes, it's a very smooth, gradual lowering of pressure. And therapeutic plasma levels, the steady state in your blood, are reached in about 7 days with consistent daily dosing.
Now let's return to demographics, because this is where calcium channel blockers really shine. We mentioned earlier that African American patients often have low renin hypertension, making those Iopril and sartan drugs less effective.
Right. Because amlodipine ignores the renin system entirely and goes straight for the muscle, CCBs are highly recommended as first-line therapy for African American patients.
And age plays a huge pharmacokinetic role here, too. In children under 6 years old, small clinical studies suggest their livers actually clear the drug so incredibly fast that they might need larger, specifically weight-adjusted doses just to get the desired response.
They metabolize it like hummingbirds.
Exactly. But then you look at elderly patients, and it's the exact opposite. Older patients have a naturally decreased clearance of amlodipine.
The liver slows down. The drug hangs around much longer.
So you have to start them on the absolute lowest possible dose and titrate up very, very carefully to avoid bottoming out their pressure.
Which brings us to the adverse effects. Because CCBs are so profoundly good at relaxing the blood vessels, they cause widespread vasodilation. And when you widen the pipes that much, basic physics and gravity take over.
Hence the peripheral edema, swollen ankles, swollen feet, swollen hands.
The blood just pools in the extremities. It's really important for patients to know this isn't because their heart is failing. It's just that the pipes are so wide, the fluid literally leaks out of the capillaries into the surrounding tissues.
You can also get intense flushing, feeling hot, headaches, and dizziness, all classic signs that your blood vessels are wide open.
Now, remember what we said about losartan and grapefruit juice? How grapefruit juice blocked the liver enzyme, preventing the drug from becoming active, so it decreased its effect.
Oh, this is where patients want to pull their hair out. For amlodipine and other calcium channel blockers, grapefruit juice is a strong CYP3A4 inhibitor. It blocks the enzyme in the liver.
But this time, that enzyme's job is to break down and destroy the amlodipine to clear it from your body.
So if you drink grapefruit juice with amlodipine, the garbage disposal is blocked. You rapidly increase the serum level of the drug in your blood. You get way too much of the drug,
Which can lead to severe toxic hypotension, fainting, and extreme edema.
Conversely, taking St. John's wort speeds up the liver, breaking the drug down too fast and returning your blood pressure to dangerously high levels.
I can just imagine a patient looking at their breakfast table saying, wait, so I can't have salt substitutes with my Sunpril, I can't have grapefruit juice with my Sunderpine, but I should avoid grapefruit with my Sartan because it does the exact opposite.
It is a massive amount of chemistry to keep straight.
It is, which really underscores why meticulous patient teaching by pharmacists and nurses is so vital. It's not just taking a pill, it's managing a chemical ecosystem.
Absolutely. We also need to mention the other drugs in this class because there is a critical life-saving quality and safety alert.
Yes, let's talk about nifedipine. It's a very short-acting calcium channel blocker, often used in extended-release formulas. What is the strict rule about nifedipine capsules?
Never, ever puncture or bite a nifedipine capsule.
Because it used to be a common practice in emergency settings to puncture the capsule with a needle, right? And squirt the liquid directly under a patient's tongue to achieve a rapid, massive blood pressure drop during a crisis.
It was.
Sounds highly effective in an emergency, though.
It is far too effective. Medical authorities no longer recommend it and, in fact, strongly warn against it because it causes such a rapid, precipitous drop in blood pressure that it triggers severe adverse cardiovascular events.
Wait, mechanically, how does dropping the pressure cause a heart attack?
It's called reflex tachycardia. When the pressure drops that fast, the brain panics. It thinks you are bleeding to death.
So it dumps massive amounts of adrenaline into your system to force your heart to beat faster to make up for the lost pressure.
Suddenly, your heart is beating 140 times a minute. But because the pressure is so low, there isn't enough force to push oxygenated blood into the coronary arteries that feed the heart muscle itself.
The heart overworks itself while simultaneously starving for oxygen, leading straight to a myocardial infarction, a heart attack, or a stroke from lack of brain perfusion.
Wow, that is terrifying. Leave the capsules completely intact.
The clinical data also mentions diltiazem and verapamil. These are non-dihydropyridine CCBs.
They are unique because they don't just relax the peripheral blood vessels. They also have a strong, direct effect on the electrical conduction of the heart itself, slowing the heart rate down.
So they are fantastic for patients who have angina, chest pain, or electrical issues like atrial fibrillation, along with their hypertension.
But it is vital that patients know that abrupt discontinuation of any calcium channel blocker can actually increase the frequency and duration of chest pain. You have to wean off them slowly so the vessels don't spasm.
All right, so we've got the enzyme blockers, the VIP receptor bouncers, and the muscle relaxers. But rarely does one single drug fix severe stage 2 hypertension entirely,
Often, prescribers use multi-drug regimens. They use lower doses of 2 or 3 different drugs to hit the problem from multiple angles.
which minimizes the toxic side effects of each while maximizing the blood pressure drop. Enter the ultimate combo players, diuretics and direct renin inhibitors.
Diuretics, colloquially known as water pills, are incredibly frequently combined with ACE inhibitors, ARBs, or CCBs.
Current guidelines actually don't recommend them as initial monotherapy for most people anymore, but they are essential combination players, particularly for African Americans and older adults.
How do they work mechanically? I mean, obviously they make you pee.
Exactly. Initially, they decrease blood volume by increasing urine output. They force the kidneys to excrete sodium. And as we established, water always follows sodium.
Less water in the pipes equals less fluid volume, which equals lower pressure.
But the clinical data reveals something really interesting happens long term. After you've been on a diuretic for a few months, your blood volume actually returns to normal. Your body compensates.
But your blood pressure stays low. Why?
It's a fascinating adaptive physiological response.
Hmm.
Long-term diuretic use causes a persistent, chronic decrease in peripheral vascular resistance.
The pharmacology points to a tiny microscopic depletion of sodium strictly within the actual walls of the blood vessels themselves.
Stripping that sodium out makes the smooth muscle much less sensitive to constricting substances like norepinephrine and angiotensin. The pipes just stay relaxed and refuse to clamp down.
The heavy hitter here is hydrochlorothiazide, a thiazide diuretic. It's the HCTZ you see tacked onto the end of so many combination drug names like lisinopril HCTZ.
There's also chlorthalidone, which the data notes has a strongly proven positive effect on reducing major adverse cardiovascular events long term.
The primary patient teaching with thiazide and loop diuretics like furosemide revolves around potassium loss. Because they flush out so much fluid and sodium, they blindly flush out potassium right along with it.
Patients will likely experience muscle cramps and fatigue, and they might need a daily potassium supplement.
Alternatively, they might be prescribed a potassium-sparing diuretic like spironolactone, which effectively dumps the water but specifically locks the potassium inside the body.
Okay, another supporting player is a drug that acts all the way at the very top of the RAAS cascade. We talked about ACE inhibitors blocking the middle of the chain and ARBs blocking the receptors at the very end. What blocks the beginning?
Direct renin inhibitors. The only one currently on the market is aliskiren.
It directly binds to and inhibits renin, stopping it from converting angiotensinogen to angiotensin to first. It stops the entire cascade before it even takes its first step.
But it comes with some serious caveats. First of all, the absorption is incredibly finicky.
The pharmacokinetics show that if you take aliskiren with a high-fat meal, its absorption decreases by a massive 75%.
You are basically throwing the pill directly in the trash if you eat a bacon cheeseburger with it.
And there is a strict, severe contraindication. You should never use aliskiren in combination with an ACE inhibitor or an ARB in patients who have diabetes.
Right. It causes a profound double blockade of the RAAS system. It drastically increases the risk of severe hyperkalemia, dangerous hypotension, and acute irreversible kidney failure.
It's simply too much blockade of the exact same system.
Good to know. Don't double dip the RAAS system if you have diabetes. Okay, we've talked about what happens when the kidneys panic, but what about when the brain hits the panic button?
What if the body's fight-or-flight sympathetic nervous system is the main culprit?
Or what if a patient is wheeled into the ER with a hypertensive crisis 220/140 and their aorta is threatening to tear? They need immediate rescue. That brings us to the antiadrenergics and the direct vasodilators.
Antiadrenergic drugs directly inhibit the activity of the sympathetic nervous system. They block the specific nerve impulses from the brain that tell the heart to beat faster and the blood vessels to constrict.
Let's start with alpha-1 adrenergic blockers like prazosin. Alpha-1 receptors are located on the blood vessels. When adrenaline hits them, they constrict.
So purocin blocks that receptor and the blood vessels dilate. But there is a huge famous warning here, the first dose phenomenon. What happens to the patient?
About 1 to 3 hours after taking the very first dose of prazosin, or any time the prescriber increases the dose, patients can experience severe, profound orthostatic hypotension.
The alpha receptors are suddenly blocked so completely that the blood vessels lose all their tone.
When the patient tries to stand up, the blood instantly pools in their legs. They get rapid palpitations, extreme dizziness, and they can completely black out and collapse syncope.
So the clinical teaching is straightforward and non-negotiable.
Mm.
Always, always take the first dose of prazosin right at bedtime, go to sleep, and sleep through the systemic crash.
Exactly. Next, we have the beta-adrenergic blockers.
The OLOLs, metoprolol, propranolol, atenolol.
Yes. These target the beta-1 receptors, which are primarily located in the heart. Adrenaline binds to beta receptors to make the heart beat faster and harder.
Beta blockers plug those keyholes. They act like a governor on a car's engine. They artificially slow the heart rate and decrease the force of myocardial contraction.
They are highly useful for patients with ischemic heart disease or someone who just survived a heart attack because they force the damaged heart to rest.
But the FDA has issued a severe box warning for beta blockers regarding abrupt withdrawal.
It is extremely dangerous. If a patient with underlying coronary artery disease gets frustrated and abruptly stops taking their metoprolol cold turkey, it can cause severe rebound angina, dangerous electrical heart dysrhythmias, or even trigger a massive fatal myocardial infarction.
Why? Because the heart suddenly wakes up.
Worse. Because the beta receptors have been blocked for months, the body responds by physically growing more receptors, trying to catch whatever adrenaline it can.
When you suddenly remove the drug blocker, the heart is exposed. It has millions of hypersensitive receptors, and it gets flooded with adrenaline.
It overworks itself to death in a matter of hours. They must be tapered off very, very slowly under medical supervision.
Okay, and finally, the emergency brakes, the direct vasodilators. When someone is in the ICU with a dissecting aortic aneurysm or a massive stroke, and their pressure is through the roof, we can't wait weeks for an ARB to build up. We need to drop the pressure now.
That is when critical care teams use sodium nitroprusside. It's given exclusively via continuous IV infusion.
It is a wildly potent direct vasodilator of both arterioles and venules. The onset is incredibly rapid, literally taking effect in seconds to minutes.
But it's practically poison if left running too long, right?
Quite literally poison. Nitroprusside naturally metabolizes in the bloodstream into thiocyanate, which is chemically related to cyanide.
If the IV infusion runs continuously for more than 72 hours, or if the patient has poor kidney function and can't excrete it, they can develop acute thiocyanate toxicity.
What does cyanide poisoning from blood pressure meds look like?
Profound nausea, vomiting, muscle twitching, severe spasms, and eventually seizures and coma.
The ICU nurses have to draw blood to monitor their serum thiocyanate levels meticulously. If it gets too high, you stop the drug immediately, and you may even have to initiate emergency hemodialysis to manually filter the poison out of their blood.
Another direct vasodilator the pharmacology data mentions is minoxidil. Now, people listening might immediately recognize that name as Rogaine, the topical hair loss treatment.
But orally, in pill form, it's a massive, absolute last resort blood pressure dropper. However, it carries an FDA box warning of its own.
Yes, minoxidil is incredibly powerful, but it can precipitate pericardial effusion.
Which means
It causes a rapid buildup of serous fluid inside the pericardial sac, the tough, fibrous balloon that surrounds and protects the heart.
if that fluid builds up too fast, it progresses to a lethal condition called cardiac tamponade. The fluid physically squeezes the heart so tight from the outside that the heart muscle literally cannot expand to fill with blood.
It beats empty and the patient dies. Because of this, oral minoxidil is strictly reserved for very severe treatment-resistant cases where all other options have failed.
All right, we have covered an immense, staggering amount of pharmacological ground today. From enzymes to receptors to calcium channels and cyanide, let's bring this all home. We need to synthesize all these microscopic cellular mechanisms into practical, everyday advice for you, the listener, who might be taking these medications at home every morning.
The clinical guidelines provide excellent, concrete patient teaching. The absolute foundation of all blood pressure management is consistency. You must take your medications at the exact same time intervals every single day. If it's a once-a-day pill, take it precisely every 24 hours.
Because if you forget, and then take two pills too close together, you get double the vasodilation, your pipes lose all pressure, and you pass out.
But if you take them too far apart, the pressure creeps back up, causing wide, dangerous hammering fluctuations in the pipes that can shear the vessels.
And as we've highlighted with nearly every single drug class today, never stop taking them abruptly. Even if your blood pressure is perfect, and even if you feel completely fine.
Because of rebound hypertension, the pressure can rocket back up to pre-treatment levels or even higher, putting you at immediate, acute risk for a stroke or a heart attack. You only have good blood pressure because of the drug.
And let's talk about orthostatic hypotension one more time. It's a huge, often ignored fall risk, especially for the elderly. When you are on these drugs, your body's natural, evolved ability to quickly constrict your blood vessels when you stand up is intentionally impaired. The drug won't let the vessels constrict.
So gravity pulls the blood to your feet, and your brain is starved for oxygen for a few seconds. You get dizzy and fall. The teaching is vital. You have to change positions slowly.
Sit on the edge of the bed for a full minute before standing. Sleep with the head of the bed slightly elevated so your body gets used to the angle.
Do some physical leg exercises, flex, and pump your calf muscles before you stand up to physically push that pooled blood back up the veins to your heart.
And track your blood pressure at home. The clinical consensus is clear that home tracking is the only accurate way to prove to your prescriber whether the medication is actually working in your real life rather than just when you are nervous in the doctor's office. Keep a daily log. Show them the raw data.
It's a true partnership between the patient and the prescriber. It might take several office visits and several frustrating trials to find the exact right drug or the right combination of low-dose drugs that safely controls the pressure without causing intolerable side effects like coughs or swelling.
So let's recap this incredible journey. We started by understanding your body's internal plumbing, the sheer mechanics of the pump and the pipes. We looked at how a little bit of weight loss and dropping the salt shaker can fundamentally change the physics of that entire system.
And then we walk through how modern pharmacology can manipulate liver enzymes with ACE inhibitors, block specific tissue VIP receptors with ARBs, physically shut down calcium spark plugs to relax muscles, flush out vascular volume with diuretics, and even override the brain's nervous system.
All of it, every single pill is designed to keep the silent killer at bay.
It is a profound triumph of targeted chemistry. But if we connect all of this to the bigger picture, it raises a provocative final thought. We now know, unequivocally, that blood pressure response is incredibly specific to age, to genetics, to race, and even to the chemical makeup of your morning grapefruit juice. The data noted that 70% of familial blood pressure issues are purely genetic.
Right, so as advanced genetic testing becomes mainstream, cheap, and accessible to everyone, will the entire concept of essential or unexplained hypertension just disappear entirely?
Will we eventually stop treating high blood pressure as a physical symptom with a pharmacy bag full of Diprils and Dimethyls?
And instead, just identify and treat the specific, tiny genetic misfire that causes it, long before the pressure ever has a chance to rise?
It's the ultimate goal. Imagine a future where we don't need to constantly manipulate the plumbing with daily pills because we simply fix the fundamental blueprint of the house before it was even built.
That is absolutely something to chew on, and hopefully the next time you look at that orange bottle on your kitchen counter, the muddy waters of pharmacology will be a whole lot clearer. Thank you for joining us on this deep dive into the incredible mechanics of hypertension. Stay curious, stay well informed, and we'll catch you next time.